Good morning, everybody. Today, Dr. Cornel is presenting for us. Dr. Engelbrecht obtained his medical degree from the University of Free State in 1999. He completed his internship at Paarl Hospital and community service in Upington, followed by work as a general practitioner in Stellenbosch. He also served as a cruise ship physician, gaining broad and diverse clinical experience. In 2017, he completed his specialization in internal medicine at the University of Stellenbosch. In 2018, he has been practicing as a specialist physician in internal medicine and critical care at Mediclinic Midstream. He is a founder of Sanocare podcast and hosts the weekly antimicrobial Star Wars series, sharing insights on infectious disease and antimicrobial stewardship. His clinical interests include general internal medicine, critical care, and metabolic medicine. He is a dedicated team player, thrives in a collaborative multidisciplinary environment, and is known for his kind-hearted nature. Beyond medicine, he has a deep love for traveling and nature, frequently escaping to wildlife reserve, and he is an avid golf enthusiast. Thank you, Cornel. You can kind of present.
Thank you very much, Mitra, for the very kind introduction. So my topic today is the ABC of LFTs. It's just a bit of, since we're doing ChemPath meetings, I thought we'll just run through some of it. So if we look at the liver is the largest organ in the body by weight. It weighs about 1.5 kilograms. And it's got two surfaces, the diaphragmatic surface and the visceral surface. And it's also divided into four lobes. You have the right lobe, the left lobe, the caudate lobe, and also the quadrate lobe. So if we look at the functions of the liver, first of all, it's necessary for biosynthesis, which is essential for fat digestion. Also has a function in protein metabolism with the synthesis, the storage and degradation of protein. There's a carbohydrate function where it produces glucose to glycogen, and then also the reverse, glycogen to glucose. It's got a function in lipid metabolism, also in vitamin A production and storage. It also has a anticoagulation function where you produce clotting factors. It plays a very important role in drug detoxification and activation. And then it's got an immunological function, especially the Kupffer cells, which is liver macrophages. If we look at the blood supply of the liver, basically gets its blood supply from the hepatic artery, and then also from the portal vein blood supply. And then the very important thing is the portal triad, and we all know this from medical school, where you have the hepatic artery, the portal vein, and then the common hepatic duct. So if we just look at a different picture of this, first of all, we all remember this hexagonal picture of the liver, where you have the central vein in the middle. You've got the portal triad at the corners, which contains a hepatic artery, a portal vein, and then also a bile duct. And then the other important thing is the zones of perfusion. First of all, the closest area is this area to the portal triad, that's zone 1, which receives the highest oxygen and nutritional support. Then you get your intermediate and then also your central lobe. That's the central lobular zone, which is most vulnerable to ischemia and to toxins. Just another picture, first of all, is you have the portal triad, and where you have the arterial and the venous flow in one direction, and then also the bile that flows in the opposite direction. So it's actually a misnomer if we talk about liver functions. Most of the things that we measure is actually liver injury and doesn't have anything to do with function. And knowing which one is which will also help you to interpret abnormal liver tests. So if we look at the markers for injury, you get your ALT, your AST, then your ALP and GGTs. And then if you look at the true function of the liver, it's actually albumin, your clotting factors, bilirubin, and then also glucose. It's always important to check your albumin and your iron R along these enzymes. So if we look at ALT, this is the most specific marker for hepatocyte injury, which is different than your AST. And this is actually quite a reliable pointer to injury of the liver. So if you have a level that is less than twice the upper limit of normal, it's usually fatty infiltration, medications, alcohol, celiac disease, exercise, and also thyroid diseases, and it's often incidental. If you've got a level 2 to 10 times the upper limit of normal, usually chronic hepatitis, autoimmune hepatitis, then also alcoholic liver disease, and then also DILI. If it's more than 10 times the upper limit of normal, it's usually associated with acute hepatitis and your ischemic hepatitis. And if it's more than 1,000 times, more than 1,000 international units, it's usually massive elevation, paracetamol overdoses, ischemic hepatitis, and then your hepatitis. And you have to assess for acute liver failure in these patients. If you look at AST, it's less specific than ALT, and it's also found in other tissue, like the liver, cardiac muscles, red blood cells, and the brain. And the first question that you have to ask is this the liver or is it something else? So we look at the AST-ALT ratio. If it's more than 2, it usually suggests alcoholic liver disease. So because your AST rises disproportionate due to the alcohol-induced mitochondrial damage. And also your B6 deficiency. If the ratio is more than 3 to 1, it's very specific for alcoholic hepatitis, and it's also important to look at your GGT and check your MCV. If your ST is more than your ALT, it's usually, and it's an alcoholic, it's usually an indication of cirrhosis, myocardial infarction, hemolysis, rhabdomyolysis, hypothyroidism, and strenuous exercise. If your ALT is more than your AST, it's usually associated with your non-alcoholic fatty liver disease, chronic viral hepatitis, and your DILI and autoimmune conditions. It's very important to remember that if you've got a raised AST with a normal ALT plus a raised drop and CK, think of myocardial infarctions or rhabdomyolysis. If we look at your ALP, it's usually found in the canicular membrane of hepatocytes, but you also find it in bone, placenta, and in small bowel. And usually, if you have a elevated ALP, doesn't automatically mean that you've got liver disease. So the first question is it liver or is it the bone? So if you've got a raised ALP with a GGT, it's usually from the liver. So that usually indicates cholestasis, biliary obstruction, infiltrative diseases, and then also drug-induced. If the ALP is normal, but if the ALP is raised, but you've got a normal GGT, it's usually from bone. So you have to think about Patch's disease, osteomalacia, bone mets, and hyperparathyroidism. If your ALP is raised in isolation, check your GGT. If both are normal, then consider pregnancy, and then it can also be physiological, like in young children who's growing. If you've got a low ALP, think about Wilson's disease, can also think about pernicious anemia, zinc deficiencies, and then also hypophosphatasia. Your GTT, it's very sensitive, but it's not specific. So the clinical value of it is confirmation test. So whether you've got a raised ALP, it's usually hepatic in origin, and this is also the most sensitive marker for alcohol use. So if you've got a raised ALP with a raised GTT, it's cholestatic. So that is what we find in biliary obstruction, your drug-induced liver injury, intrahepatic cholestasis. If you only have an isolated GGT, it's very indicative of alcohol disorders. This is also the most sensitive marker. If you've got a raised GGT plus a raised MCV with macrocytosis, it is surely alcohol. And then the next one is you look at your bilirubin. So if you have a bilirubin of more than 35 micromoles per liter, it's indicative of jaundice. And we all remember this from medical school, and I'm not going to go into the whole process of bilirubin metabolism and the excretion. But for bilirubin, you get your unconjugated bilirubins that's raised, and that's usually prehepatic or your indirect. That's hemolysis. You have to think about Gilbert syndrome and a couple of other things. If you've got raised conjugated bilirubins, that will be the cause of all liver diseases, cholestasis, biliary obstructions, Dubbin-Johnson, and then also Richter syndrome. So your conjugated bilirubins or your direct bilirubins is water soluble, and it usually appears in the urine and it makes the urine dark. And then your unconjugated bilirubin is bound to albumin, and it can't be filtrated into the urine. So if we look at albumin and your INR, and as I said, this is the true markers of your liver synthetic function. So raised enzymes, if you've got raised ALTs, enzymes, ALT, but normal albumin and INR, it's usually an indication of preserved liver function. So if we look at albumin, the reference range is usually about 35 to 50 grams per liter. Half-life is about 20 days, so it doesn't acutely form. So low albumin is usually indicative of chronic liver failure, dietary problems, nephrotic syndrome, your protein-losing enteropathies. And if it's not liver, low albumin doesn't always mean liver failure. If you look at the INR, this is where you get your factors 2, 5, 7, and 10. And this is all liver synthesized, and it's like your vitamin K dependent liver enzymes, and with a half-life of about 6 hours. So if it is raised, think of liver failure, warfarin toxicity, and also your vitamin K deficiencies, DICs. So there's a couple of pattern recognitions that we can use in assessing these liver enzyme tests. So first of all is hepatocellular. So what we do is you work out the ratio formula where you take your ALT and you divide it by the upper limit of your ALT level, divided by your ALP level, divided by your LP of the upper limit. So if you've got very raised ALTs and ASTs proportionate to the ALPs and your ratio is more than 5, then you think about things like viral hepatitis, autoimmune conditions, DILIs, those kind of things. If you've got a cholestatic pattern, your ALP and GGTs will be raised. Your ratio is usually less than 2. And then you will think of your biliary obstructions, your PCs, and also your primary sclerosing cholangitis drugs. for those patients, you check, you do an abdominal ultrasound, you can do your autoimmune markers, even a CRP, MRCP. If you've got a mixed pattern, that's where the ratio is between 2 to 5. And then both patterns can be elevated. You think about your drug-induced liver injuries, viral hepatitis, and also your cholestatic patterns, autoimmune conditions. Then if you only have raised isolated bilirubins, so normal enzymes with raised bilirubins, so those are the two conditions are your unconjugated is like your Gilbert's or hemolysis, and your unconjugated conditions is Stubborn-Jones and early cholestasis. And then if you've got an infiltrative pattern, things like sarcoidosis, lymphoma, amyloidosis, METs, you will have disproportionate ALP with modest rise in your transaminase levels. So what is the approach to abnormal liver functions? So the first step is to distinguish what is the type of pattern. Is it cholestatic or is it hepatocellular? And you calculate your R ratio for that. Your second step is how raised is it? So is your levels less than 2 of your upper limit of normal? And it's usually benign, and you can just monitor it. If your level is between 2 to 10 times the upper limit of normal, then you have to investigate it. And if it's more than 10, you have to consider acute liver failure. The next is to look at the synthetics function, and that's where we check the albumin, the INR, and also the glucose. The fourth step is to find out about your drug and alcohol history. So drug-induced liver injury is very common and it's reversible. And we usually check it, stop the offending drug, and you check it about 4 to 6 weeks later and see if it's returned to normal. And then you can go on to your targeted investigations. You can look at your hepatitis, your autoimmune screen, iron, alpha-1 antitrypsin, for your copper, and then also an abdominal ultrasound. So there's a couple things, pills that we can use, so that will give you an indication of what underlying condition there is. So if you've got an AST and ALT ratio of more than 2 to 1, it's usually alcohol related until proven otherwise. You can check your GGT and your MCV to confirm the diagnosis. If you've got a low LP, it's good to think about Wilson's disease. So if you've got a raised ALT with a normal GGT, you think about bone as a source and not the liver. So it's actually ALP. It's my mistake there. If you've got isolated, unconjugated bilirubins, think about Gilbert's and also hemolysis. And Gilbert's is a benign condition that we usually find in patients where they present with raised bilirubins with an underlying infection. Also check your LDH and your reticulous count and also your film on blood. If your ALTs are more raised than more than 1,000, think about paracetamol ODs, ischemic hepatitis, and also your viral hepatitis. If you've got a raised INR with encephalopathy, think about acute liver failure. So enzymes don't tell you, well, enzymes basically tell you that the liver is injured, while albumin and INR tells you that the liver is failing. So, and it's important never to interpret your enzymes without checking your ALT or your albumin and your. So the last couple of slides are basically, because we see this a lot of times, where you find mildly to moderate elevated serum ALT, ASTs, and it's usually less than 15 times the upper limit of normal. It usually can be divided into two diseases. It's basically your hepatic diseases and then your non-hepatic diseases. So your hepatic diseases, you look at if it's ALT or AST predominant, and they all have different causes for it. And if it is non-hepatic, then you will think about your other things like rhabdomyolysis, adrenal insufficiency, myocardial infarctions, thyroid diseases, anorexia, celiac disease. Yes, and that is a quick summary of liver function.
Oof, thank you. First, welcome up everyone for our presentation. It's really been very nice to be here again. We took quite a long break. This is amazing. Thank you, Cornel. I know we put you under pressure to give us a ABC of liver function, and I think this really did quite amazing, very amazingly so. The reason that because liver function is what we see on a daily basis, but also at the same time we miss quite a lot of how to interpret them. It's really become quite very difficult because you really need to understand how to kind of easily to interpret the liver function quite very well. And one of the things come out of course is that AST-ALT ratio is quite a very good pathognomic of the alcohol. But I know that AST also could be elevated in other conditions, which I think Karabo presented before when the patient got a bit of rhabdomyolysis. So it's also found into your muscle enzymes, which as part of muscle enzyme also. And also previous in the past, I think was used for diagnosis of myocardial infarction as one of the criteria, but I think as time goes on, it got phased out. So my biggest question is that how much alcohol do I need to drink for my liver function to be going that way? Can I pick it up early because I love my wine?
So I think if you binge drink, obviously you will get a transient effect. We see it more in the patients who's drinking chronically. That's where you will find the raised GGTs, CMV, all the other. But I think the liver usually can take quite a big knock. But if it becomes prolonged, so we all know that the healthy intake for adults, I think it's 21 units for men per week, women 14 units. So in that region, you will still be safe. I think it's more when you start drinking heavily, chronically, when it becomes a big problem.
And then drinking with food, like increased fatty acid, if you drink with the fatty meals, does that affect? Because I heard that when you drink on empty stomach, the risk of chronic alcohol intoxication is quite high compared to fat.
No, I think the fat basically produces a layer, so the alcohol doesn't get absorbed as quickly, but it will get absorbed. So, but then also with the liver function, and I've seen there's lots of nice little apps where if you get abnormal liver tests, you basically feed your liver enzymes into an app, and Up to Date has a nice one, and it will tell you then what to look for, what diseases to think about. So that is actually something that's quite nice. So you don't have to go and do the calculation. It will actually work out the calculation. You will fill in the values, and then it will give you an answer of what.
And the liver function and paracetamol overdose? When do we actually use it as a marker? How much paracetamol do I need to take before my liver function actually start going haywire?
Well, once again, I think it varies from person to person. It's the same as alcohol. So some people will be more sensitive than other people. And especially we see a lot of paracetamol ODs, and I always check for a day or two afterwards that you don't get a rise in your in your liver enzymes. So we never just test it once.
Do you have certain racial groups or maybe clinical phenotypes of people who are more prone to having liver dysfunction on a insult, like a minimal insult, like maybe you get IV antibiotics or IV perfalgan, for example, and then suddenly the liver function goes deranged?
So once again, it also varies on what is the underlying condition, what other medications patients are taking, so, and then also alcohol use.
Or does it have to do with fatty liver as well? If you've got fatty liver underlying and then you've got an insult, does that predispose?
Well, I think there's more probably to do with your metabolism of whatever you're taking, like correction, like paracetamol or alcohol, everything. I think it's the cyto, I'm not so sure what the cytochromic, but more to do with the antioxidant depletion, and the liver function really come out of it because you need acetyl acetylcysteine to to bind into some of the toxin to kind of neutralize it. And now, if you're having issues with that, so those patients are more prone to develop kind of recurrent liver injury. And I think probably it's kind of genetic kind of issues, which is more related to genetic, if I remember very well. But I think gastroenterologists might answer that quite a lot better. But I think there's a lot to do with more oxidant, how to actually neutralize your toxin. And those who see them with patients with the gut issues, patients with the liver problems, and so the list goes quite endlessly. So I think there's correlations to it. Yeah, but I also know that there are people who take about 2, because they say you need to take something like 4 paracetamol, 1 gram for a day. Some people go through liver failure if they're having those kind of conditions. Yeah. So especially when they have underlying process, isn't it? So yeah. So I think there's quite a lot of issues that you must actually have to look at it. But I think it's always very important that any patient needs to have a baseline liver function. By the same time, conditions like Gilbert, conditions like Cryer-Najjar syndromes, and all of them, those conditions really, they just like you don't have really enough. There's kind of partial deficiency or enzyme or conjugations, and those patients sometimes in stressful conditions, their liver function goes up. And once they stress, whether it's sepsis, whether UTI, whether alcohol, the liver function bilirubin goes up, and after that, actually comes down. But not equivalent to the liver failure, but more to do with the overwhelm of your conjugation vehicle. I think it's more the thing. Yeah. Sanet, what about drugs? Which one should we be worried about?
TB
I know you're
drugs.
still on the birthday mode.
I think the paracetamol I think is one of our biggest, and then the second biggest that we find in our setting is the TB drugs, of course, the lead. I think we had a few patients on certain antibiotics. We had liver-induced liver toxicity, so it's always important to keep that in.
I think I think the cytochromic P450 and the inducers is something that you always have to look at. That's why in critical care we tend to not use a lot of PPIs, because PPI is one of the, I think we had that discussion about the indication of PPIs in ICU. Together we try to avoid that in the context of in the context of the obviously in the context of the liver inducers. Online, anybody? Dr. Kohli? I know you are there. Karen?
Good morning. No question from my side. Great presentation.
Prof. Karen?
Yes, good morning. Good morning, Cornelius. Thank you for a very good presentation. I just have a comment or two. It's always interesting to keep the half-life of the enzymes in mind as well, especially looking at the ALT-AST ratio after an acute insult like ischemia or toxins. You need to realize that the ALT has a long half-life of about 50 hours, while AST has a half-life of about 18 hours. So it depends on when you're looking at this ratio, and it might be worthwhile to actually look at it serially to see what the ratio is actually doing. Looking at something like GGT, we like to use it as a marker for alcohol. The half-life is quite long. It's 10 to 14 days. And one would expect it, if the patient would abstain from alcohol, to normalize after about 28 days or a month. So it's quite important, especially for our insurance testing. It's interesting just to realize that as well. Also on the question of alcohol exposure, GGT is not only specific for alcohol, but anticonvulsants can also induce the enzyme. And there it might be worthwhile to look at a marker called carbohydrate deficient transferrin, which will rise once the patient exceeds 40 to 60 grams of alcohol per day. So quite interesting. Yeah, thanks.
You're talking about grams. Okay, that's amazing. How much, if I take a glass of wine, that damage my liver?
Yeah, you'll have to take
here-
about 3 glasses of wine with 13% alcohol, and then you will have a high CDT level.
Every day.
On a chronic basis,
Chronic
not once off.
basis. Okay, I'll cut down. Dr. Godinho, I know you can. How's the weather out? All right. Any other questions online? So if there's no question, otherwise we'll resume again next week, Wednesday and Thursday. I think next week, Wednesday, and who's presenting?
I think Lazelle, is immunology topic.
Okay, so we're gonna have immunology. That's always exciting. You know, it's always to be nice to vent into a territorial that you're not very familiar with. So we're looking forward for that. And I think Thursday also we might have presentations also. In this case, if there's none, you can consider the meeting closed. And it's really a week of Cornel's birthday. So hopefully we'll have to sing for him before he just disappears in the midst of the mist in the air. Thank you.
Thank you. Thank you. Bye-bye.